let me just tell you reality for a lot of people who do not study this subject, who do not read books, who do not come to conferences. Reality for a lot of people is it's 8 o'clock on Wednesday night, they're watching their TV, commercial comes on, really attractive woman and attractive man, they're happy, they're on the beach, they got a dog, there's a kid nearby, a slogan comes on that says, live your life to the fullest, don't let anything hold you back, and it talks about some drug. You know that we live in a country where we have the FDA to protect us, to make sure everything is safe and can't hurt us. You go to your doctor who says, yes, this is what I recommend, take it. And you're told that you don't know about medicine, you weren't trained in it, you should definitely take this if you have high blood pressure, if you have high cholesterol, if you have gout, if you have all these different things. And it seems pretty good. And you ask your friends, and your friends say, yeah, that's what you're supposed to do. You're 50, this is what happens to people, you're getting older. And this is good, and we have the best medicine in the world, and we have protection from the government agencies. So what's different about this? This is what a lot of us think. So in your opinion, what do you think reality is? Because that's the reality that a lot of people have. What's really going on in your opinion?
Well, I'll just share some research that really came out of his book, but it's excellent research, and so I don't mind taking it. When we look at antipsychotics, antidepressants, and anti-anxieties, there's a consistent pattern that unfolds. In the short term, they may look a little better. You give somebody Haldol in an acute psychosis and give them a day or two and it's going to help. However, go a few weeks and a few months down the line, then you're looking at getting it worse. The same thing, and particularly 1 year relapse. And the same thing holds true with the antidepressants and really anti-anxieties. For example, Xanax was researched pretty extensively. First 4 weeks, it's good, you're getting some relief. 8 weeks, break even. 23 weeks, oh, you're worse. Now what I mean by worse means you're having more anxiety, more panic attacks, and if you withdraw from it, you got 4 times more panic attacks and considerably more anxiety, worse than when you started. The pattern is worth understanding. Now, I'm going to go back to antipsychotics for a moment. The research generally, and some of this was done by Jonathan Coles and other, very, very high-ranking people, is the longer you're on it, the worse it is, because there's more brain deterioration, particularly in the basal ganglion. And the higher the dose you're on it, the more relapse. And some of the research was done with early one Thorazine, and it's like, fine, you're at 300 milligrams, you're going to have a 13% relapse, and then you go a little higher, 500, and you're up to 21, 23% relapse, and then you go higher, and you're, how much higher relapse. But what are we really saying? And it's also true with the antidepressants, although antidepressants have another problem, which is well described, which is they move you into the next level of mental breakdown. What am I saying there? I'm saying people get on antidepressants they have who are just depressed, okay? And next thing you know, there's a high percentage that are converting to manic depression. Oh, now manic depression means you get put on the antipsychotics, and the next thing you know, you are chronically disabled. And so you see a flow of chronic degeneration with very little results. And in fact, the research with the antipsychotic shows that after a year, although it helps in the first little bit, there's a much more relapse, we call it 5-year relapse and so forth, or 3-year relapse, than if you don't take any medication. So that's an important statement, that people actually do better not having medication. And that's there, it's in the journals, it's in the National Institute of Mental Health Research, high-level research. So I'm going to say it again. People actually do better in really short-term and long-term results if you do not take the antipsychotics, because they do interfere, sometimes somewhat irreversibly, with your brain structure. I'm not going to go into the biochemistry of it, but That's what we're talking about. And that is a serious problem. And it happens with all of these. And the withdrawal can cause even worse effects. So that's 3 levels where we're using drugs regularly. So I think that's part of the more serious element of it. But to me, the bigger element that's more serious isn't all the fact that they don't work. And they make things worse. Got to count that in there. Not that they just not work, you're causing harm. As physicians, you're not supposed to harm people. Okay. Now, the next thing is it's a whole attitude in society. Got a problem? Pop a pill. Don't change your life. Don't look at how you can grow spiritually. Don't ask any questions about your soul evolution. Just try to suppress the symptom. So it's an anti-evolution from a spiritual point of view type of situation. And that's going on now parents are busy, they're so busy working, and I want to honor the parents with that. It's like, oh, there's no diagnosis of manic depression for kids that's legitimate, if you get what I'm trying to say. It's just an opinion. Is it ADD? Is it manic depressive? Is it just a normal kid a little bit active? They don't actually have, let's say, a real test for any of that. So it's very subjective, and the parent is kind of worn out. Hey, I'm busy working. I just can't deal with this. Let's pop a pill. It's taken care of. It's not my responsibility. It doesn't matter what kind of diet I'm giving them. Nothing matters. It's just take a pill. It's a congenital physiological defect. It's just not true. So we take hyperactivity and all those altered brain states, and what we see is it's really accelerated by poor diet, high sugar diet, and all the other toxins that are going on, including now we're going to add radiation from all the kids being exposed. And 75%, the research is showing, is treatable with proper nutrition and lifestyle changes. If you're getting a little fancy, Joe Furman and myself both are talking 90% success rate with this kind of thing with the full attention. I mean, give people homeopathy, we do this, we do that. You get really good results at 9, and so what's the problem? The problem is, where are people at? I don't want to just blame the doctors, in other words. I want the society to begin to reflect on that and what's coming out of that, and the parents and the school system. Hey, this kid's a little active. Let's put them on. They're too active. Let's not bother the teacher. Let's just take care of it. And this is a very, very serious problem. And as one doctor there's a whole book that kind of has all the symptoms in it. And Robert Spitzer was like the first. I actually knew him at Columbia. But the second person and head of that, Francis, okay, saying something very interesting. He's saying, I regret what's going on. He's saying the border between normality and manic depressive has started to disappear. And I'm actually thinking, I don't want to misquote him, but thinking that I'm doing, this has done, the DMS 3 or 4 has done some real harm, because you're categorizing people even with normal development and putting them on drugs that ultimately create brain changes in the children. We don't even know what that's going to look like. This is really bad news. So there's a lot of kind of collusion in the whole thing. So those are my concerns, is a society that says, oh, let's make everybody the same. Anybody's out of line, they need a drug. So this is the kind of issues that are going on. Now, I thought it was interesting that Francis actually said that. He actually said, if kids are a little out of line, he didn't use those words, but slightly unique, they're more likely to get on a drug, because we have a society, everybody wants to be normative. And that's what's happening to our society, which is not necessarily awakened normality, put it that way. So those are kind of an overview insight that I want to share.
I'm just going to go. I just want to follow on a couple of things, going back to what Steve was saying and then what Dr. Cousens was saying. So one of the truisms that we know in society today is that everybody with schizophrenia should be on antipsychotics for life, okay? We have laws organized to that idea. We have forced outpatient treatment laws, and that's considered an absolute fact. So 3 quick facts that you don't hear about even while you're getting these commercials. One, John Nash died on Saturday. Do you all know John Nash, A Beautiful Mind? Mm-hmm. So he died on Saturday. Now, do you remember the movie?
Yes.
What does Russell Crowe say before he's going to get the Nobel Prize? He says, I'm better now because of the newer medications. Okay, that's what he says. Do you know what really happened? John Nash refused medication, starting in 1970. What's that? Yes, in 1970, once he got out of his last hospitalization, actually he refused it all the time when he got out of the hospital in the 60s, but 1970 he stopped. And if you actually read the biography, it says, it's good that he stopped because otherwise, because of the effects, including tardive dyskinesia, these drugs and the mental fog they produced, he would have never returned to work. So the truth was, he stopped. It was probably why he was able to return to work. And you know what Americans were told in the movie? Because we get our... is that the newer medications was what enabled him to recover. Now that's an example of the perversion of truth that becomes so problematic. Now, how did that get in the script? Well, the scriptwriter's mother was a psychiatrist, that's number 1. But 2, I think the PR firms that worked for the drug industry worked with the scriptwriter because there was an article about how they had got that line planted in the movie. And then when the movie came out, drug reps like Gwen, I don't know if you did this in the United States and Canada, they handed out free tickets to the movie, didn't you?
Yeah, I sold Haldol.
Yeah, okay, so they handed out free tickets because it supported the belief in this. So that's one bit of information. 2, I'll give you another bit of information. This goes back to something Dr. Cousens just said. The best long-term study of outcomes for schizophrenia patients that's ever been done in the United States has been done by Martin Harrow at the University of Illinois. He followed 200 patients starting back in the late 1970s. 15 years later, he had 145 patients still in his study. That's very good to keep 77% of your, quote, schizophrenia patients, psychotic patients. Just naturalistic, he follows them. Everyone treated with drugs in the hospital, then he follows them at 2 years, 4.5, 7.5, 10, 15, and 20. And here's what he found. At the end of 2 years, those who had come off were not really doing any better than those who were on. It was very close. And both were still showing a lot of pathology. But between years 2 and 4.5, those who got off meds did a lot of recovery. They got a lot better on a lot of domains. Psychotic symptoms abated. Many went back to work. Anxiety symptoms abated, such that by the end of 4.5 years, the recovery rate for those off medication was 40%. That meant they were working or back in school, asymptomatic, and had no psychotic symptoms. For those on medications, it was 5%, an 8-fold higher recovery rate. Now that stayed through 15 and 20 years. And how about psychotic symptoms? At the end of those who stayed regularly on the medication, 75% were still actively psychotic at years 10, 15, and 20. Those off medication, and particularly those who got off and stayed off, only about 25% still had psychotic symptoms. 87% of those who got off by year 2 and stayed were working and back in school and stuff, fairly regularly during that time. Virtually no one on drugs worked. Okay, now all of you who've read that in your local Orlando newspaper, the results of that study, please raise your hand. Come on, that's the best long-term study we've had of schizophrenia outcomes. How come you didn't read about it? You know what Martin Harrow said in 2008 when he went to the American Psychiatric Association meeting? I conclude that those off antipsychotic medication long-term psychotic patients have significantly better global outcomes. Why didn't you hear this? I'm asking you. Let's say the results were the reverse, and 40% of on drugs were in recovery versus 5% off. Would that have made news? Front page. This is a problem. It's an information flow problem we have too around this, is that when outcomes like this go that really upset conventional wisdom, we don't hear about it. And by the way, the psychiatric residents, if you look at their textbook, it doesn't incorporate that study correctly into the psychiatric textbook as well. This perversion even extends as well to there. Anyway, this is, when I hear about the TV commercials, it's just propaganda, folks. And the problem is, okay, it's propaganda, but these other stories, they also get suppressed when we have, and then you get the Menashe story that's changed, which is very, was very symbolic. And then here we have the best long-term outcome study ever done of schizophrenia patients. And it's actually good news. Those off medication, there were psychotic symptoms were abating. More than half were working. Good social lives. You know what some of them became? There was like a lawyer, there were teachers. Now, those people who were diagnosed with schizophrenia and became lawyers and teachers, do you think they now say to their peers, I was diagnosed with schizophrenia for 5 years? We don't hear about that, right? So these disappear. This is why this is the very study we should be talking about and we should hearing about, and that should help us guide our care. And finally, one other thing. You know where they get the best outcomes for first episode psychotic patients in the world today, in the Western world? Northern Finland. You know what Northern Finland did? They have a form of care that really looks at psychotherapy and increasing social interaction. It's called open dialogue therapy, and they minimize use of antipsychotics. 2/3 of their patients, 5 years out, have never been on antipsychotic medication, so they never get these brain changes. So given that this is the best results we see in the Western world, what should we be doing in the United States? Trying to pilot it, trying to copy it, right? But that doesn't get promoted. You don't read about that in your Orlando newspaper. So this is the problem. What you're getting at is we have an information problem that makes it really difficult for our society to know about these drugs, their effects, what they do to the brain, et cetera.
Can I add something to that? I'd just like to add that I sold Haldol, and I remember when I was first being trained on Haldol, I asked my district manager during a training session, I said, how many patients have we cured with Haldol? I mean, how many patients recover on Haldol? And he said, oh my goodness, hon, nobody recovers on these drugs. These patients don't recover. In fact, we have what's known as a revolving door syndrome, that each time that they come into the hospital for treatment, they go out with a greater disability than they came in with. And so we don't look for cures, we just look to manage the symptoms of these individuals. And that's the reason why we're coming out with Haldol decanoate, because so many people do not want to take their medications that we're going to now put them on board for 30 days so that we don't have to have them remember or take their own medications. And I said, whoa, wait a minute. In studying the side effect profiles of these, some people really have serious reactions to Haldol. If you have it in a decanoate, how are they going to remove the drug when they have an adverse reaction? Well, we're really not concerned about that. We're just concerned about you need to convert your Haldol tablet sales now, because that has gone off patent, and now we have this new patent for this decanoate, and so you need to get all of those sales converted into that, including your nursing home. And so I got a very crash course, immediately, in that we're not concerned about what happens in outcomes with patients. We're concerned about the bottom line of our drug portfolio, and that's what you need to be concerned about. So that was a big, my first aha moment, and there were numerous incidents like that to follow. So I really want you to be aware that from the inside, they're very well aware that these drugs don't work, and they are keeping this information undercover for profit, pure and simple.
I'd like to address both that issue and the issue that Bob Whitaker raised. And I can also attest that the drug companies are very well aware of the data and how ineffective the drugs, and I'm talking about just one particular class of drugs right now, and that's antidepressants. So when you ask about antipsychotics, I will defer to my esteemed panelists, and I think I know more about antipsychotics and the problems of antipsychotics from reading Bob Whitaker's book than I do from any other source. But I can address directly the issue of antidepressants. And I know I was contacted by two pharmaceutical companies who asked me to come down and speak to them. And both of them told me the same thing. They said, well, we don't see why there's such a big fuss and controversy about your research, showing how small the difference is between antidepressant and placebo. We know that. We have trouble showing significant differences between the drug and placebo. And in fact, what we'd like to do is find a way to more reliably detect who's likely to respond to placebo in a clinical trial and get them out of the trial so that we have a better chance of showing a difference between drug and placebo. And they were very forthright, frank, and open about that. The media is an issue, and it's an important one, but it's not the only issue, because I had a somewhat different experience with the antidepressant research. I got some excellent media coverage. First meta-analyses I did got covered in the New York Times, it got covered in Newsweek, it got covered in USA Today. They were on it and came out with stories the day that it was published. They interviewed me before it was published. A press release had been sent out that the information was embargoed until the study actually comes out, but they could prepare themselves to publish it. In 2008, when my research came out, my second meta-analysis, its third meta-analysis, with the FDA data, the British press jumped on it, and it wound up being the front page news in all of the major British newspapers. And then when my book was translated into English, not translated, I can't say, it was written in English, when it was originally published in the UK, when the US edition came out, Newsweek jumped on it, and they did a 5-page cover story. And 2 years later, 60 Minutes picked it up, and they did a full segment on it. So it got a lot of publicity. Hasn't made much of a dent in the psychiatric community despite that publicity. The former head of the American Psychiatric Association, after the 60 Minutes segment was aired, wrote a press release and said that 60 Minutes had been irresponsible in airing this segment and that Kirsch's research had been refuted. They didn't say by whom or on what basis. 60 Minutes, to their credit, responded by saying, we stick with our story. So, but what happens? I don't get, yes. I have to say my eyes were really opened by the amount of thoroughness, the degree of thoroughness that the 60 Minutes, the producers of that segment went through. They would call me on the phone every week or two and say, did you see this new study that came out? What do you say about that? Until they aired the story, they stayed very much on top of it. So I didn't get that much hostility from the pharmaceutical companies even. I got hostility from 2 quarters. The psychiatric community, not all psychiatrists, some have been wonderful and supportive, but by and large, the psychiatric community, and not pharmacologists, they're fine with it, psychopharmacologists. I asked why. I asked this, I do research in a lot of areas that involve, I do research on placebo effects, and I do that in a lot of areas. So I've done studies on placebo effects in migraine, placebo effects in irritable bowel syndrome. And in irritable bowel syndrome, most of the treatments that they have, just about all of the treatments that they're using now for irritable bowel syndrome, they're not terribly effective. They're a little bit, some of them a little bit better than placebo, but not that much. The story's not that much different, except they tend to be not dangerous things. I mean, asking someone to have more fiber and probiotics is a good thing, not a bad thing. But we did 2 studies on irritable bowel syndrome, looking at the placebo effect, and the principal investigator was the head of gastroenterology at Beth Israel Deaconess Medical Center, and I asked him, Tony, we come up with these data, and they're very similar to the data that we came up with in depression, that the placebo seems to be as effective or close to as effective as the medications that are being used to treat IBS, irritable bowel syndrome. But you and your colleagues don't seem at all defensive about it. You're friendly to the data. You listen to it. I've been asked to give a keynote address at a pediatric gastroenterology conference, and it was not to debate me. It was because they were interested in the placebo effect and how they might make use of it in the treatment of IBS. But my psychiatric colleagues, many of them are so hostile, and so I wonder, why are you and your colleagues so friendly and receptive to this? And he said, Irv, you know, we have a lot of things that we do. We know that medications for IBS aren't that effective, but we do a lot of other things. And you know, if you were to tell us that colonoscopy didn't do anything, we'd be as hostile as the psychiatrists are. They don't have anything else. They got out of the business of doing psychotherapy decades ago. So their livelihood is being threatened by it. That's all they have. And you know the old saying, if all you have is a hammer, everything looks like a nail.
Right. Absolutely.
I just want to say one thing about 60 Minutes and maybe why the reception was different. The 60 Minutes piece came after Marcia Angel did the thing in the New York Review of Books.
Yes.
And your book was reviewed, my book was reviewed, and Daniel Carlet's book was reviewed. So 60 Minutes did come to me as well. But I'm not in the 60 Minutes. And part of the point is there's a little bit of a difference here, I think, that is revealing. So if you look at Irving's work, well, first of all, he brings an academic credential to it as well. But one, he's tapping into somewhat of a societal unease about the antidepressants. And two, he's not exactly saying that drugs, at least at first glance, that the drugs are doing harm. It's just they're not particularly more effective than placebo. And that's sort of a questioning of this story that I think is okay. It's not talking about drugs doing harm, it's just they're not that much more effective than placebo, and it became a doorway into sort of questioning this, but it's another step to say, you know, these drugs may be harming people, causing bipolar disorder, that sort of thing. I'm just saying, I think 60 Minutes is great, but even 60 Minutes didn't dare go a step further here, and I think that's part of the, you know, Irving's work was like opening a door to a story, and it was the perfect door to open to this story because it was, it didn't focus attention on harm done. It focused on less effective than we might think. And that does open the door to a whole nother story, but I think that's why it shows how hard it is to open that door, is basically what I'm saying, fully open.
I have a comment too on that because I had a friend that was still in the pharmaceutical industry, and of course you're also my mentor, so I've read all of your work as well. And I asked her at the time, because she was selling a psychiatric drug and also an antidepressant, or an antipsychotic and an antidepressant, and I said, so, you know, how's the company going to handle this information that came out? Because, I mean, this has to be devastating. She says, no, actually, it's played right into the company's marketing plan. And I said, why? She said, because now we're coming out with treatment-resistant depression so we can get them to continue taking their antidepressants, but we're going to add on our antipsychotic drugs so it actually gives us an avenue to sell our new antipsychotics. Fact. And wasn't it right after that that treatment-resistant depression became a diagnosis?
Vilify.
Yay!
Yes.
Seroquel, right?
Seroquel, that's what it is.
Yes, Seroquel.
Actually, there is a story that just came out in the press. That's how I found out about it a couple of days ago on treatment-resistant depression and people that have been treated unsuccessfully with antidepressants, and they have found something that seems to work well for these people who have been resistant to antidepressants for all these years, and it turns out to be mindfulness.
Between mindfulness and exercise, you really have some equally effective treatment to any drug. So what happened? Okay. Batteries out. between mindfulness and physical exercise, they are equal or better than traditional drug treatments. That's what we're seeing.